Hi everyone. Today I'm going to continue with chapter 8 and I'm going to present the second part with related to the joints. So here we are going to talk about some diverse synovial joints. We are going to talk about the knee, shoulder, elbow, hip and the jaw joints. Let's go one at a time. Knee joint is the largest and most complex joint of the body. It actually consists of 3 joints surrounded by a single cavity. So the 3 joints would be the femoropatellar joint, which forms the joint between the femur and the patella. So it's a plain joint and it allows gliding motion during the knee flexion. And the lateral joint and the medial joint are the 2 other joints, and collectively it's called as the tibiofemoral joint. And these joints between the femoral condyles and the lateral and medial menisci of the tibia. Menisci are some articular disc which you find in the articular capsule, and it would partially divide the synovial cavity into 2. So what will happen with this articular disc is that it will improve the fit between the articular bone ends, so the bone joint may stabilize and it would minimize the wear and tear of the joint surfaces. So the knee joint, this tibiofemoral joint, the hinge joint, and they allows flexion, extension, and some rotation when the knee is partly flexed. The knee joint, the joint capsule is thin and actually it's absent anteriorly. So in anteriorly, joint is stabilized by the quadriceps tendons, which gives rise to its 3 broad ligaments, and that would run parallel to the tibia. So the medial and lateral patella reticula, which flanks the patella ligament, provides this stability. And you might heard the word knee-jerk reflex. That is where doctors try to see with the reflex with related to the ligament, the patella ligament. And there are lots of bursae associated with the knee joint, and actually it's kind of 12 bursae associated with, and that is to prevent friction in between the bone surfaces, which makes the knee joint, and it prevents rubbing these tendons or the ligaments and the muscles with bones together. It prevents the rubbing feature. The capsule, the knee joint ligaments, actually we can divide them into capsular ligaments, extracapsular ligaments, or intracapsular ligaments. And all these capsular, extracapsular, or intracapsular ligaments, they're going to stabilize the knee joint. The capsule and the extracapsular ligaments help to prevent the hyperextension of the knee. And the fibula and tibial collateral ligaments, they prevent the rotation when the knees extend. The oblique popliteal ligament, that would stabilize the posterior knee joint, and the arcuate popliteal ligaments, they would reinforce the joint capsule posteriorly. So you need to know the location of these ligaments and what those ligaments provide, what is the function. The intracapsular ligaments, they reside within the capsule, so that's why it's called intracapsular, but they do not belong to the synovial cavity, so they're of course outside the synovial cavity. And these intracapsular ligaments prevent the anterior and posterior displacement, especially when we are standing. The anterior cruciate ligaments, it attaches to the anterior tibia, and it prevents the forward sliding of the tibia, and it prevents moving further away. And it stops hyperextension of the knee. The posterior cruciate ligaments, it attaches to the posterior tibia, so it prevents backward sliding of the tibia and the forward sliding of the femur. So here it shows the sagittal section of the right side of the knee joint. You would see the distal end of the femur, the proximal end of the tibia. You would see the articular discs, which is the menisci on top of the tibia, and the patella, which is in the and you would see the patella ligament over here, where you test for the knee jerk, and you would see the bursae, which is lying in between two bones, and you would find the highlighted ones, the red ones, the anterior cruciate ligament, the posterior cruciate ligament, the intracapsular ligaments, and also the subcutaneous prepatellar bursae is important because it's mostly subjected to rupture due to lots of time kneeling down for the most of the day or so. And here in this anterior view of the right knee, you would see the stabilization ligaments, which is from the tendon of the quadriceps of the femoris, and then the medial patellar reticuli, the tibial collateral ligaments, as well as the patellar ligaments over the anterior aspect of the knee. And this would be the posterior view of the joint capsule, including its ligaments. You would see oblique ligament going across it, the fibiocollateral ligament, the arcuate ligament, the tibial collateral ligaments, and tendons of the semimembranous muscles. So posteriorly, it's a tendon of the semimembranous muscles. The anteriorly, you would find the quadriceps tendon. Here it will shows the superior view of the right tibia and the knee joint, and it shows the menisci and the cruciate ligaments. So these are the two cruciate ligaments, and this is the posterior cruciate, this is the anterior cruciate, this is the lateral menisci, the articular surface, this is the medial menisci. And of course, this is again showing the anterior and posterior cruciate ligaments with its attachments. So with related to the clinical aspects, the knee, it absorbs great amount of vertical force, but it's subjected to horizontal blows. It's not stabilized horizontally, so it can subjected to lots of trauma due to lateral or the horizontal blows, and especially you would see it in hockey playing players, that if the stick or the disc is hitting the knee joint, because they come in horizontal blows, and you would see the knee joint injuries. The common knee injuries would be in 3 C's, the collateral ligament, the cruciate ligaments, and the cartilage menisci injuries. The lateral blows to extended knee, which can result in tears in the tibial collateral ligament as well as medial meniscus, and also the anterior cruciate ligament. So this would be maybe an MCQ point, giving a scenario saying like a hockey player had a blow on this to the knee joint. So what ligaments or what structures would get affected in the knee joint? And injuries affecting the anterior cruciate ligaments, they are common in runners who change directions, twist, and they can have the twisting anterior cruciate ligament tears. The next big joint, the big synovial joint or the large synovial joint that we need to know is the shoulder or the glenohumeral joint. This is the most freely moving joint in the body, and because it has to provide a wide range of movement, the stability of the joint has been sacrificed for the freedom of its movement. This is a ball and socket joint, the head of the humerus, which is not a fully formed sphere, it's a hemisphere. So the large hemispherical head of the humerus fits into the small, shallow glenoid cavity of the scapula. So articular capsule enclosing the cavity is also thin and loose, and that allows it to have a great range of movements. So here you would see that the uh, glenoid cavity over here, and you would see the hemispherical head of the humerus. And as in the same, as you saw it in the knee joint, you would find some bursae, subacromial bursae over here. You would find tendon sheath. This is the long head of the biceps brachii muscle, and the tendon is being covered by a tendon sheath, and the fibrous layer of the, and also some bursae over here. We talked about this, and you would find like subscapular bursae and all those things in a bigger picture. But what I wanted to emphasize is it's been these bursae would help to prevent friction between the bony ends which formed the joint. And you would find the synovial cavity of the glenoid cavity containing the synovial fluid, as well as the articular cartilages surrounding the articular surfaces. So in the shoulder joint, you formed a rim around the glenoid cavity. We called it as the glenoid labrum, and that will little bit make deeper, to give a deep feature to the glenoid cavity, because if you actually look at a bone, you don't see it as a cavity as it is. So the glenoid labrum makes the cavity a little deeper, so the head would be a little stabilized in that case. The glenoid labrum is made from fibrocartilaginous rim, and as I mentioned, it helps to add depth to the shallow cavity, and the cavity still only holds 1/3 of the head of the humerus, even it does have the glenoid labrum. So the stability of the shoulder joint is provided and reinforced by the ligaments. It's primarily on the anterior aspect, the coracohumeral ligament. It runs from the coracoid process to the humerus, and it helps to support the weight of the limb. This is the ligament which holds actually the weight of the upper limb. And there are 3 glenohumeral ligaments which strengthen the anterior capsule, but they are providing kind of a weak support. So here is the one which shows the coracohumeral ligament, the coracoid process to the humerus, coracoid process of the scapula, and goes to the humerus, and also the articular capsule reinforced by the glenohumerus ligaments too. And you would find the subscapular bursae, the tendon sheaths, the subacromial bursae, which provides the preventive ability with related to the friction when the joint moves. So here it shows the glenoid labrum as well as glenohumeral ligaments. So this view shows like how much the ligaments play a role in order to stabilize the joint. Also, there are muscles which reinforce the shoulder joint, and the tendon of the long head of the biceps brachii muscle is the super stabilizer of the shoulder joint. In addition, there are 4 rotator cuff tendons encircling the shoulder joint. They are the subscapularis, subsupraspinatus, infraspinatus, and the teres minor. You might remember these as from their first letters. You can make it like cyst. So S-I-S-T, subscapularis, supraspinatus, infraspinatus, and the teres minor muscle tendons. So here it shows the rotator cuff muscles, even though it's not clear as like individual muscles. These tendons further reinforce the shoulder joint. The elbow joint is also found in the upper limb. The humerus articulates with the radius and ulna in the elbow joint. This is a hinge joint. It's formed primarily from the trochlear notch of the ulna, articulating with the trochlea of the humerus. It allows for flexion and extension only. And the annular ligament, which surrounds the head of the radius, is associated with the elbow joint. So there are two capsular ligaments which restricts side-to-side movement of the elbow joints. They are the ulnar collateral ligament and the radial collateral ligament. And also, this is showing the sagittal, median sagittal section right at the elbow joint. You would see the tendons of the triceps muscles posteriorly, and also the tendon of the brachialis muscle anteriorly, as well as you would see the articular capsule and some bursae associated with the articular cartilage and so on. And in this figure, it shows the annular ligament, which surrounds the head of the radius, and the radial collateral ligament, which reinforce the elbow joint. The other important synovial joint would be the coxal joint. This is a ball and a socket joint like the shoulder joint. The difference is the sphere of the femur is fully formed, so the socket is deep as well, so it provides a great stability with related to this joint. So the large spherical head of the femur, it articulates with a deep cup-shaped acetabulum in the coxal bone, and it provides actually good range of motion, but it would not reach the amount that a shoulder joint can provide. So, but because the limited because its range of movement is limited by the deep socket. So the acetabular labrum is also the rim, is a rim that you find in around the acetabulum. This is formed by fibrocartilage that enhances the depth of the socket. So therefore, hip dislocation is much more a rare condition. So here, if you would see in the frontal section that this is the head of the femur, this is the coxal bone, the acetabulum, and you would see it's much more a deeper socket, and it occupies almost kind of the whole head of the femur. And the ligaments, of course, reinforce the hip joint. The reinforcing ligaments include the iliofemoral ligament, pubofemoral ligament, ischiofemoral ligament, and the ligament of the head of the femur. The greatest stability comes from the deep ball and the socket joint itself, and you would see that obviously it's a great fit between the acetabulum and the head of the femur. And here you would see the different ligaments, the iliofemoral ligament, the ischiofemoral ligament, which stabilize the hip joint. Anteriorly, you would see the iliofemoral ligament as well as the pubofemoral ligament. Lastly, you would find a synovial joint in the skull bones. The facial and the cranial bones involvement, the temporomandibular joint. This is the jaw joint, and it is a modified hinge joint. So the mandibular condyle, it articulates with the temporal bone, and the posterior temporal bone, it forms the mandibular fossa, and the anterior anterior of it forms a portion called the articular tubercle. So the articular capsule, it thickens into strong lateral ligaments in this joint, and you would see the articular capsule over here in this figure, and you would see the mandibular fossa over here. You don't see the anterior tubercle, but you would find it over here when you remove this lateral ligament of the temporomandibular joint. Yes, so here it shows the mandibular fossa, over here the articular tubercle anteriorly, and you would see the condylar processes of the mandible over here, and the inferior joint cavity over here. There is an articular disc, a little menisci in the temporomandibular joint, and it separates the joint cavity into the superior joint cavity and the inferior joint cavity. The two types of movements provided by the temporomandibular joint would be the hinge joint. Its depression and elevation of the mandible happens when the hinge joint is functioning, hinge movement. With the gliding movement, it provides side-to-side movement. So it's like the movement which happens when you try to grind your teeth. Because of the anatomical position of the temporomandibular joint, it's the most easily dislocated joint in the body. And if you look at the previous picture, it's been anteriorly dislocated and lies in this infratemporal fossa. So the physicians, what they need to do is they have to open the patient's mouth, they have to push down and backwards to relocate the joint back into its physiological position. So dislocation of the temporomandibular joint is the most common because of the shallow socket of the joint. It always dislocates anteriorly, causing mouth to remain open, and the physicians, they realign them by pushing the mandibular back into place. With related to the clinical aspect, the dislocation of the TMJ, temporomandibular joint, gives rise to symptoms of the ear and face pain, tender muscles, some popping sounds when opening the mouth, sometimes joint stiffness. And this is usually caused by grinding teeth, but it could also due to jaw trauma, or maybe sometimes due to poor occlusion of teeth. So as treatments, you can give grinding teeth. For grinding teeth, you can provide bite plates, and also you have to relax the jaw muscles to reduce the stiffness of the joints. So the next important topic of this chapter, after discussing the joints, would be discussing the disorders of the joints. So the common joint injuries would be the cartilage tears. It could be due to compression and shear stress. And fragments can cause joint to lock or bind. And cartilage rarely repairs itself. So therefore, you have to remove these damaged cartilage from the injured joint. And you repaired it with some arthroscopic surgeries. Those are using modern day technology. The other one would be the sprains. So these are the stretched or torn ligaments, and especially when the reinforcing ligaments are stretched or torn, we call it as a sprain. The common sites would be the ankle, knee, and the lumbar region of the back. The partial tears, it repairs very slowly because we know that the ligaments, they do not have a very good blood supply. It's poorly vascularized, so it takes time to heal. The three options, if torn completely, is either ends of ligaments can be sewn together. It's like sewing two brushes together, a very tedious process, and either it could be replaced with grafts, or it can just allow time and immobilization would heal the tear. Also, dislocations or luxations are also a common injury. So bones in dislocation, bones forced out of its usual alignment. And this could be accompanied by sprains, inflammation, and difficulty um, in moving joints. And it's caused by serious falls or contact sports, and must be reduced to treat. So the treatment, we call it as reduction of the dislocations. The word subluxation is sub means partial, so it's a partial dislocation of the joint. In addition, you can have conditions with associated structures of the joint, which is bursitis and tendinitis. Itis involved inflammation. So bursitis is the inflammation of the bursae, which is usually caused by blow or friction. And treatments include resting and applying ice. And if it's severe, you can use anti-inflammatory drugs. In tendinitis, inflammation of the tendon sheaths is typically caused by the overuse, and symptoms and treatment similar to those of the bursitis. Also, in arthritis is a common condition you would encounter. There are more than 100 different types of inflammatory or degenerative disease which damage the joints. The most widespread crippling disease in the US would be the arthritis, and the symptoms include pain in the joints, stiffness in the joints, swelling of the joints, and sometimes the acute forms is caused by the bacteria, and you have to treat with antibiotics in that case. The chronic forms are the osteoarthritis, rheumatoid arthritis, and the gouty arthritis. Also, you might have heard this several times, osteoarthritis, with a common condition you would find with related to the joints in older age. So this is the most common type of arthritis. This is an irreversible degenerative arthritis. So the joint subjected to wear and tear, and it may reflect excessive release of the enzymes that would break down the articular cartilage. And the cartilage is broken down faster than it's replaced. The bones spurs, we call them as osteophytes, start to form from the thickened end of the bones. This leads to friction of the bones, and this osteoarthritis usually happen with the normal aging process. Due to the osteoarthritis, joints become stiff, and it may produce some crunching noise when you walk or use that joint. And this crunching noise referred to as crepitus. And this would be seen like when somebody's start to stand up in a sitting position, you might heard this crepitus in the knee joints or maybe in the back and so on. The treatments would be the moderate activity, mild pain relievers, and some pain relieving creams. Also, glucosamine, chondroitin sulfate, and nutritional supplements. People used to take it, but it's been said with now recent research findings, the difference between the placebo and the treatment itself would be the same, but still people use it. The other common condition or inflammatory or degenerative condition would be the rheumatoid arthritis. Unlike it's in old age, this is commonly seen at younger age. Not young means like from your 30s to 50s, but of course there are exceptional cases that you might see it even before that. So chronic inflammatory disease is rheumatoid arthritis. It's an autoimmune disease, which is the cause is unknown. In autoimmune diseases, your immune system would not able to recognize your own tissues, own body tissues as your own body. So they think that they are foreign and they produce antibodies against those. So the immune system attacks their own cells with related to rheumatoid arthritis, and especially they targeted the joints. Usually it's around between age, I would say 30 and 50s, but it may occur at any age, and it affects 3 times as many as women as men. So it's a common disease in women. The signs and symptoms include joint pain, swelling. It would be bilateral. That's a key feature with rheumatoid arthritis. Anemia, osteoporosis, muscle weakness, and cardiovascular problems. The rheumatoid arthritis, it begins with inflammation of the synovial membrane of the affected joints. The inflammatory blood cells, they start to creep into the joint and release some inflammatory chemicals, and those chemicals then destroy the tissues. The synovial fluid tend to accumulate, and the accumulation cause joint swelling, and the inflamed synovial membranes then start to thicken up and into abnormal pannus tissue, which can cleanse the articular cartilage. And if the pannus tissue it's erodes cartilage, you would form a scar tissue forms and connects the articulating bone ends. We call it as the ankylosis. The treatments for rheumatoid arthritis include steroidal and non-steroidal anti-inflammatory drugs, which decrease the pain and inflammation, destruction of joints by immune system, and also it can replace joint with prostheses. The other important inflammatory condition would be the gouty arthritis. In this condition, deposition of uric acid crystals is happening in the joints and soft tissues, and this is going to be followed by inflammation. And this is a disease in men, like it's commonly seen in men, and typically affects the joint at the base of the great toe in your lower limb. And if untreated, it can result in bone ends fusion and immobilization of joints. As a treatment, it's recommended to drink lots of water. There are medications, and avoid alcohol, food high in purines, such as liver, kidneys, and sardines. Also, Lyme disease, it's a bacterial disease which affects your joints. The Lyme disease is transmitted by tick bites. The symptoms include like skin rash, flu-like symptoms, and it could ultimately leads to joint pain and arthritis. And of course, you have to treat the Lyme disease with a long course of antibiotics. So this is the end of the presentation too. Thank you.